you able to see my slides now?
No, madam.
Yeah. Let me see. I'm sharing again. Can you see?
Now we can see. And
Yeah,
it's moving. That's the title slide now.
Yeah, but this is not a PowerPoint presentation, if that's all right.
Then that's not a problem. Okay.
Okay. Believe you can see all the slides now.
Yeah.
Okay.
This is a
All right,
PDF.
so yeah, it's a PDF.
Okay. You can scroll down and proceed.
Okay. All right. So I'll just take up the first question once more quickly. Okay. So you have a 25-year-old woman. She came for routine checkup, no complaints, regular cycles. And you have done a PV examination, and we find that the uterus is anteverted and palpable through the anterior vaginal wall. The examination findings are consistent with normal anatomy. Which of the following describes a normal position of uterus in most women? I'm certain that you know the answer to this one. The uterus is normally anteverted and anteflexed. Okay. What I wanted to stress here was the supports of the uterus. The uterus has got three different kinds of support. You've got the ligaments. We have got the ligaments. Then we have got the muscles, and you also got the mechanical support. The ligaments will include the cardinal, the transverse cervical or the McEnroth's ligament, pubocervical, and the uterosacral, where the cardinal ligaments, pubocervical and uterosacral together form the triradiate ligament. Then we've got the muscles, of which the most important is the levator ani. And also they've got the superficial and deep transverse perineal muscles and the bulbospongiosus. And again, the mechanical support. The mechanical support is the one that we're talking about, which is anteversion and anteflexion. Okay. Anteflexion is the angle that is formed between the uterus and the cervix. It is an obtuse angle and it is around 120 degrees, whereas anteversion is the angle between the cervix and the vagina, almost a right angle, which is 90 degrees. All right. Then we got a couple of things I want to tell you. First step in pelvic organ prolapse is loss of anteversion. That is, the first step is retroversion of the uterus. A fixed retroverted uterus is a characteristic of endometriosis. And one question that has been repeated over and over again is, which is the ligament that does not support the uterus? The ligament that does not support the uterus is the broad ligament. Okay. Can you see the second question? I hope this is visible. So we're taking up the second question.
Yes.
For hormonal study, sample should be taken from which wall of the vagina? So again, instead of discussing this particular question, what I wanted to say was a few things regarding the vagina. We'll start with the blood supply of the vagina. Which is the artery that supplies the vagina? The main arterial supply of the vagina is from the internal iliac artery. That is, from the branches of the internal iliac artery, we've got the uterine artery, the descending vaginal artery, the internal pudendal artery, and the middle rectal artery. These are the arteries that line the vagina. See? The uterine artery, the descending vaginal, the internal pudendal, and the middle rectal. All branches of the internal iliac artery. Then another thing with regards to the vagina is, you know this one, vagina is lined by a non-keratinizing stratified squamous epithelium. What is the importance of the non-keratinizing stratified squamous epithelium? Why are we stressing it? This particular kind of epithelium is resistant to gonococcus. So the practical aspect is that an adult female is resistant to gonococcal vaginitis. But in newborns, the lining of the vagina is by transitional epithelium. So theoretically, newborns are susceptible to infection with gonococcus. Newborn vagina is susceptible to infection with gonococcus, while in adult females, the vagina is resistant to infection from gonococcus. Now, you often find the patients complaining of vaginal discharge. One important thing you have to remember is that there are no glands in the vagina. So where does the discharge come from? The discharge, mainly the discharge is from the endocervical glands. Then you also got the endometrial glands and the Bartholin's glands. Okay. And what is the pH like? What is the pH of the vagina? The pH of the vagina is acidic, which is mainly due to Dodderlin's bacilli. pH of the vagina is acidic. And after menopause, this Dodderlin's bacilli will disappear from the vagina, which makes the pH alkaline. So anyway, our question was, for hormonal studies, sample should be taken from which wall of the vagina? For hormonal study, sample is to be taken from the lateral wall of the vagina. What about for a cytological study? What if you're going for a pap smear? For a cytological study, sample is taken for, if this is for hormonal study, this is for hormonal study. If it is a cytological study, for cytological study, sample is taken from the posterior wall of the vagina. That is cytological study in the sense, for a, if you're going for a pap smear, if it is a pap smear that you want to take, the sample is taken from the posterior wall. Okay, that is with regards to the vagina. Next question, question 3, which is true regarding ovary. Mesovarium contains ovarian vessels. Ovarian ligament connects ovaries to the uterus. Ovarian fossa is related to ilioinguinal ligament. And the suspensory ligament of ovaries connects ovaries to the uterus. Like we have been saying over and over again, this is not so that you can get the correct answer to this particular question. A couple of things about ovaries that I want to cover here. First of all, with regards to ovary, the ovary is the only structure in the abdomen that is not covered by peritoneum. We'll go one by one. Mesovarium contains ovarian vessels. What is mesovarium? Mesovarium is a structure that connects the ovary to the broad ligament. It does not contain any of the ovarian vessels. We have to talk about the ovarian vessels. The ovarian vessels are actually found in the suspensory ligament. What is the other name for the suspensory ligament of the ovaries? The suspensory ligament of the ovaries, also known as the infundibulopelvic ligament. I believe you'll be more familiar with this term. The infundibulopelvic ligaments are the ones that contain the ovarian vessels, which is why during hysterectomy, their bleeding is very likely from the infundibulopelvic clamp, the infundibulopelvic or the suspensory ligament. That is where we have got the ovarian vessels. Now, what about the ovarian ligament? What does it do? The sentence is true. Ovarian ligament is the one that connects the ovaries to the uterus. And we've got the ovarian fossa. The ovarian fossa is related to the ilioinguinal ligament? No, the ovarian fossa is actually related to a nerve. The ovarian fossa is related to the obturator nerve. I've got the picture of the ovarian fossa here. And this structure that comes down this way, this one here, that is a ureter. You have also got a question like that. What is the relationship between the ureter and the ovary? Ureter is located in the posterior wall of the ovarian fossa. That is another thing with regards to the ovary that you need to know. What is the relation of the, you're all familiar with the relation of the ureter and the uterine artery, but with regards to ovary, ureter is located in the posterior wall of the ovarian fossa. Next question. Before ovulation, which of the following is seen? Now we've got the hormone profile. You've got LH and FSH. It's just LH and FSH that are being given here. Before ovulation, what is, whether do the hormones rise? Do they fall? What happens to LH and FSH? Before ovulation, all the hormones, LH, FSH, estrogen and progesterone, the levels of all the hormones are high. You are familiar with the LH surge. You know that ovulation occurs 32 to 36 hours after the LH surge and around 10 to 12 hours after the LH peak. Now, progesterone synthesis, the maximum value of progesterone comes in the luteal phase. That is not exactly at the time of ovulation, after ovulation. But the synthesis of progesterone starts around 36 hours before ovulation. And so at the time of ovulation, we find that the levels of all the hormones are high. FSH, LH, estrogen, and progesterone. The levels of all the hormones are high at the time of ovulation. Okay. The answer is, which of the following is seen? The FSH. All the following can occur under the effect of estrogen except. What happens to the cervical mucus under the effect of estrogen? The cervical mucus becomes thin and stretchable. Menstruation occurs under the effect of estrogen. Breast development also occurs under the effect of estrogen. But what about hair growth? Hair growth occurs, whether it is in males or females, hair growth always occurs under the influence of testosterone. When does this start? Actually, the production of testosterone occurs from around 8 to 9 weeks, and hair growth is under the influence of HCG. Hair growth is stimulated by testosterone. This is another one. The maturation index on vaginal cytology is a diagnostic method for evaluating what? Before we go into that, we'll just discuss what the maturation index is. The vaginal epithelium has got three different types of cells. The basal and the parabasal cells, the intermediate cells, and the superficial cells. You got three types of cells, that is the basal cells, the basal and the parabasal cells. We have the intermediate cells and the superficial cells. Now, each of these cells is predominant at a particular time or a particular age in life. If you're talking about the basal cells, it means that the basal cells have got, there's no hormonal predominance for the basal cells. So they are mostly seen, or a maximum number of basal parabasal cells are seen during menopause and in childhood. While the intermediate cells are dependent on, so here basal cells, no hormones. While the intermediate cells, they are seen in a condition where progesterone is the predominant hormone. Where is progesterone predominant? Progesterone is predominant in pregnancy and in the second half, that is the luteal phase of the menstrual cycle. So that is when the intermediate cells are seen more. Then we've got the superficial cells. Superficial cells are more under the influence of estrogen. When is that? During the first half of the menstrual cycle. All right. So we've got three different kinds of cells: the basal, parabasal cells, the intermediate cells, and the superficial cells. All these three cells occur at different times in life depending on the hormones. Now you come to the maturation index. That is a question, right? What is the maturation index on vaginal cytology for? The maturation index shows the relative percentage of these cells per 100 cells counted. How many basal cells? The relative percent. What is the percentage of basal cells? What is the percentage of intermediate? What is the percentage of superficial cells per 100 cells counted? So the maturation index is given as A by B by C. That is parabasal is to intermediate is to superficial cells, right? That is how you calculate the maturation index. So already you must have found an answer to that. What does it evaluate? What is this? How are these cells formed? Under the influence of what? Under the influence of different hormones. So the maturation index on vaginal cytology is a diagnostic method for evaluating the endocrine status of the cervix or with regards to the hormones. Right. So with regard to maturation index, there is a couple of other things that you need to know. It is not possible to by heart all of the maturation indices, what happens when. You have to know that under the influence of which hormone, which cells are predominant, that you have to know. And a couple of other things, that is in a child. We have already discussed this. What happens to a child? In a child, which are the cells that are predominant? It is a parabasal cells. That is, the hormones are very low in a child. So the parabasal cells are predominant, followed by the intermediate cells. The maturation index in a child is 80/20/0. Okay, this one you have to know. This is mostly because of the steroid hormones which are present there. In a pre-ovulatory phase where estrogen is a predominant hormone, there are more of superficial cells. So it will be 0/40/60. Another important thing that you need to know is in pregnancy. What about the maturation index in pregnancy? Which is the predominant hormone? It is progesterone. We have already discussed that progesterone hormone influences the growth of the intermediate cells. In pregnancy, it is 0/95/5, where 95 is the percentage of the intermediate cells. In menopausal period, this question has been asked before. What happens in menopause? We have discussed before. The hormones are very low. There is hardly any hormone. So the most of the cell, almost all of the cells are basal or parabasal cells. So the maturation index will be 100/0/0. Okay. I hope this is clear for you. You cannot by heart all of them. You have to know which cells, which hormones, and you need to know about a few of ones that are commonly asked. That is, what is the maturation index for a child? What is it like in pregnancy? And what is it like in menopause? Okay. Let's go to the next question. Features of post-ovulatory endometrium on ultrasound is. This is another interesting question. How does endometrium look on ultrasound? This gains more importance when you're studying fertility, all right? But still, you have to know what the endometrium looks like. All these are, whatever is given here, whatever the choices are, they're all features of the endometrium at different stages of the menstrual cycle. I'll just show you the picture. See, you've got three different endometrium, three different ultrasound pictures of the uterus with endometrium in three different phases. First off, here you can see that it is the early proliferative phase. That is, say this is just after menstruation. What is it that you see here? What you're seeing is this one here, this white part that you see, this is a single hyperechoic line. It is a hyperechoic line, and this is called the central endometrial echo. See how the line goes. There is just a single line. It is a hyperechoic line. This is seen just after menstruation or in the early proliferative phase. Now you're coming to the time of ovulation. By the time ovulation has occurred or during the late proliferative phase, you find that there is a halo. This here is a halo. You've got a trilaminar appearance of the endometrium. 1, 2, 3. There you have that is a trilaminar appearance, means there is a central thin line which we talked about before. There is a central thin line. There is a darker echolucent rim in the middle. This here, just on either side of the central echogenic line, you've got the darker echolucent rim, and it is surrounded by an echogenic basilar layer. That is what gives it the trilaminar appearance. You do not have to know what the trilaminar appearance is, but know that at the time of ovulation or in the late proliferative phase, the endometrium will have a trilaminar appearance. While in the early proliferative phase, it is or just after menstruation, we have got the central endometrial echo. And now you come to the next phase, which is the secretory phase of the endometrium. Here, that is the luteal phase. It has got the maximum endometrial thickness. See, the endometrium is this thick. That is a maximum endometrial thickness. There is a hyperechoic endometrium. On the whole, the endometrium is hyperechoic. You do not find that you do not find the trilaminar appearance. You do not see the 3 lines. There is a loss of the 3 line sign, and there is a prominent posterior enhancement of the endometrium. All right. So we have gone through 3 different phases of the endometrium. Look at the pictures. You can also get pictures from the ultrasound asking you to identify. This is the one that is most important, where we have got the trilaminar appearance. First of all, there is a central endometrial echo. Then you have got the trilaminar appearance. There is, in this phase, this is the phase where you see the halo sign. There is no posterior enhancement. It is in the secretory phase or in the luteal phase that the endometrium is maximally thick. The endometrium is hyperechoic, the halo sign is lost, and there is prominent posterior enhancement. Now, what was the question? What is a feature of a post-ovulatory endometrium on ultrasound? Where do you see a single hyperechoic thin line? This is seen in the just after menstruation, early proliferative phase. What about the 3-line sign? The 3-line sign and the prominent halo are both seen at the time of ovulation or in the late proliferative phase, while a prominent posterior enhancement is a feature of a post-ovulatory or a secretory endometrium. All right. So you've got those pictures. I believe you have understood that. Let's take the next question. What is a false statement regarding spasmodic dysmenorrhea? Before we move on to spasmodic dysmenorrhea, what is dysmenorrhea? Dysmenorrhea is a painful menstruation that is enough to incapacitate day-to-day activities. I'm sure that you all know this. You must have definitely seen patients, young children especially, with dysmenorrhea coming to the gynecology casualties. Dysmenorrhea is of 2 types, primary or spasmodic dysmenorrhea and secondary or congestive dysmenorrhea. In a primary dysmenorrhea or spasmodic dysmenorrhea, we find that there is pain that lasts for, never lasts for more than 48 hours. The pain is usually located to the lower abdomen or the lower back. It may radiate to the thigh. There may be some systemic discomfort in the form of, vomiting or loose stools. Here, in primary dysmenorrhea or spasmodic dysmenorrhea, there is basically no pelvic pathology. This is mostly seen in the adolescent age group, in children with or in people with ovulatory cycles. All right. So how do you treat spasmodic dysmenorrhea? The treatment most commonly is by NSAIDs. Prostaglandin synthase inhibitors is the first line of treatment for spasmodic dysmenorrhea. If there is no relief, we know that this condition is associated with ovulatory cycles. So if there is no relief, you can make the cycles anovulatory by administering combined oral contraceptive pills for 3 to 6 cycles. Very rarely, dysmenorrhea may require surgery. What is the surgery that is done for dysmenorrhea? The surgery for dysmenorrhea is just very rarely, if ever done, but just for theory's sake, you can dilate the cervical canal. You can administer a paracervical block. We're talking about spasmodic dysmenorrhea, all right? Or you can give a presacral neurectomy. Presacral neurectomy or a uterosacral nerve ablation. So that is how you treat a spasmodic dysmenorrhea. First line treatment is NSAIDs. If NSAIDs do not work, then you should try to make anovulatory cycles using combined oral contraceptive pills. Still not working, the girl is suffering from severe pain, you can give the option of surgery, which includes dilatation of the cervical canal, a paracervical block, or presacral neurectomy or uterosacral nerve ablation. The next kind of dysmenorrhea, the second kind, the secondary dysmenorrhea or congestive dysmenorrhea as it is called, is associated with a definite pelvic pathology. It is usually seen in the reproductive age group. It can occur with anovulatory cycles also. We said primary dysmenorrhea or spasmodic dysmenorrhea is a feature of ovulatory cycles, while secondary or congestive dysmenorrhea can occur with anovulatory cycles also. It actually starts 3 to 5 days before the periods. It is not relieved when the period starts, and it is a deep-seated pelvic pain, not like a lower abdominal pain or low backache. It is a deep-seated pelvic pain without any radiation. And it has got definite causes, like we said. It can be due to PID, it can be due to endometriosis, it can be due to adenomyosis, it can be due to some intrauterine contraceptive devices, fibroids, polyps, stenosis, lots of any kind of pelvic pathology can cause the congestive dysmenorrhea. So what is the treatment? Since there is a definite pathology, the treatment is to treat the underlying cause. Okay. Now here, spasmodic dysmenorrhea, how long did we say that it lasts? It never lasts for more than 48 hours. So the pain will not persist for 2 to 3 days. Okay. Let us go to the next question, question 9. Which of the following pregnancy complications are associated with PCOS? Another topic that is very familiar to all of you, polycystic ovarian syndrome. What are the clinical characteristics of PCOS? As far as pregnancy complications are concerned, before that, let's just divide PCOS into 3. That is, we've got the common symptoms, then we've got the pregnancy-related problems and the sequelae of PCOS. What are the common symptoms? Usually, a girl with PCOS will present with irregular cycles, that is, menstrual disorders, then hirsutism, acne, acanthosis, alopecia, obesity. All these are common conditions with PCOS. Now, what are the pregnancy complications? This is what we need to know here. The pregnancy complications of PCOS are, first off, difficulty in becoming pregnant, that is, infertility. Along with infertility, you can write OHSS also, include OHSS also. What is OHSS? Ovarian hyperstimulation syndrome, which occurs during treatment for infertility, especially in HMG-induced cycles. We will discuss OHSS in a later question. The pregnancy complications include infertility, OHSS, recurrent pregnancy loss, spontaneous abortions, possibility of gestational diabetes mellitus, possibility of preeclampsia, possibility of preterm labor or PPROM. Especially we see that in women with PCOS who become pregnant, there is always a likelihood of cervical incompetence. So going in for preterm labor. These are the main pregnancy complications that are associated with PCOS. What was it? Infertility, OHSS, RPL, JDN, preeclampsia, and preterm labor. So what are the pregnancy complications? You can include all of the above. Okay. What were the sequelae of PCOS that also you're familiar with? If the person can go in for type 2 diabetes, you can have hypertension, dyslipidemia, coronary artery disease, fatty liver, even adenocarcinoma of the uterus. We're continuing with this topic. We have a young lady who presents to the gynecology OPD with complaints of primary infertility, excessive weight gain, and hirsutism. Laparoscopy shows the following finding. What is the most likely diagnosis? Always when you get infertility, weight gain, and hirsutism, you'll most likely go for a diagnosis of PCOS, right? You got 4 choices: Turner syndrome, pituitary, PCOS, and bilateral dysgerminoma. Look at the picture. The image shows bilaterally enlarged ovaries. Are you able to make out the ovaries in the picture? These are the ovaries. The image shows what? Bilaterally enlarged ovaries. And they've already given a history of weight gain and hirsutism. In all likelihood, this is a PCOS. Anyway, let us just look at the choices once more. First of all, you've got Turner syndrome. Turner syndrome is gonadal dysgenesis. So instead of enlarged ovaries, you'll have streak gonads. Then we have pituitary tumors. In pituitary tumors, the size of the ovaries usually never increase, because when there is a tumor of the pituitary, LH and FSH will be low. Even though very rarely ovarian size may increase, but the other symptoms, that is excessive weight gain or hirsutism, will not be associated with pituitary. Then we have got bilateral dysgerminoma. What is dysgerminoma? Dysgerminoma is a germ cell tumor. They'll have bilateral enlarged ovaries. But since this is a cancer, there is no way that the patient will gain weight. The patient will be cachexic. The patient will have weight loss. There will be rapid growth of the tumor and be associated with abdominal pain. So none of these agree. In this case, our answer is PCOS. couple of things about PCOS. I'm sure you know about the diagnostic criteria. What is the name of the diagnostic criteria? The diagnostic criteria is called Rotterdam criteria. Rotterdam criteria includes, you need any two of three, that is or either ovarian dysfunction, clinical or biochemical evidence of hyperandrogenism, and polycystic ovaries on ultrasound. So that is with regards to the diagnostic criteria. We won't go into the details. How do you treat this? What is the treatment? What is the treatment of PCOS? First of all, the first treatment is lifestyle modification. Then you'll have combined oral contraceptive pills, especially with third generation progesterones like desogestrel, like drospirenone. That is the second line. First of all, lifestyle modification, then combined oral contraceptives with third generation progesterone, insulin sensitizers like metformin, and surgery. This is the surgery for OHSS. What is this? I'm sorry, not OHSS, for PCOS. This is an ovarian drilling. In ovarian drilling, there is something called the rule of 4. Rule of 4 means there will be 4 punctures which go for a depth of 4 millimeters, and there is a 40-watt current that is given for 4 seconds. That 4 punctures, 4 mm, 4 seconds. That is a rule of 4 for ovarian drilling. Ovarian drilling is used for the surgical management of PCOS. Question 11. A 22-year-old woman comes for treatment of hirsutism. She is obese and has facial acne also. Serum LH is 36, FSH is 9. Androstenedione and testosterone levels are mildly elevated. Serum DHEAS is normal. The patient does not wish to conceive at this time. Which of the following is the most appropriate treatment for her condition? Here you got hirsutism with alteration in the LH-FSH ratio. LH is more, FSH is less. And in this condition, she's obese, she has facial acne. Most probably, the woman is suffering from PCOS. Like we said before, PCOS, lifestyle modification. But here, what is the most appropriate management? Lifestyle modification is not there in the choice. The first line management after lifestyle is OCPs. They've specifically said that the patient does not wish to conceive at this time. So the management is OCPs. Let us just discuss a little bit about hirsutism. The drug of choice for hirsutism is OCPs. Then again, you've got finasteride. You have to know these drugs which are used for hirsutism. OCPs, finasteride. What is finasteride? Finasteride is a 5-alpha reductase inhibitor. Then we have androgen receptor antagonists like spironolactone, like cyproterone, flutamide. Then we've got GnRH. Then we have eflornithine. But you have to remember that once a woman has got hirsutism, it is very difficult to remove all her hair through these means by giving medicine. For permanent removal, for permanent control of hirsutism, she'll have to undergo a laser treatment or electrolysis of her hairs, whatever hair she already has. Okay. Menopause. HRT. The term HRT is no longer used. The term is MHT or menopausal hormone therapy. It is indicated in menopausal women for what? What is HRT given for? Now, what is menopause? Menopause is cessation of menstruation for at least 1 year. Around 51 years is the age internationally. In India, that will be around 47 years. Menopause, if you are using a hormone to detect menopause, the hormone to be used is FSH. If FSH is more than 25, it is suggestive of menopause. But an FSH value of more than 40, especially on 2 occasions, 4 weeks apart, is diagnostic of menopause. Not just FSH, there is increase in LH also, but there is decrease in the estradiol. Increase in FSH and LH, while there is a decrease in estradiol. The menopausal estrogen is estrone. Estrone is formed from the adipose tissue. Now, here we are talking about the hormone replacement therapy. The hormone therapy that is to be given for menopausal women. The most important thing with regard to the treatment is that the clinical features, all the clinical features of menopause are caused due to hormone deficiency. The most important thing in treating this is that you have to address any specific cause. In this case, uterine bleeding, CA breast, or endometriosis are not menopausal symptoms for which hormone therapy is required. So hormone therapy is indicated for hot flushes, which is caused due to the deficiency of estrogen. How do you administer menopausal hormone therapy? First of all, let's start with vaginal symptoms. If the woman has got only vaginal symptoms, that is, she's complaining of vaginal dryness, then you'll give her vaginal estrogen or some lubricants or moisturizers. First, you'll start with the lubricants, then you go for vaginal estrogen. That is if she has vaginal symptoms only. Now, a menopausal woman with an intact uterus, like we said before, the symptoms of menopause are caused due to lack of estrogen. So, in this case, you know that she requires estrogen, but her uterus is intact. In a woman with an intact uterus, if you're giving estrogen alone, she may later develop endometrial hyperplasia. So in that case, what you'll be giving will be a combination of estrogen and progesterone. That is for a woman with an intact uterus. But if she is post-hysterectomy, then you can offer her estrogen alone, which can be transdermal or oral. Now you see here something called tibolone. What is tibolone? Tibolone is a STEAR, that is selective tissue estrogen activity regulator. Tibolone has got estrogenic, progesterogenic, and androgenic properties, which can be used as menopausal hormone therapy. Then we also got some non-hormonal treatments for menopause. The non-hormonal treatment will include drugs like SNRIs, like venlafaxine, SSRIs, which include paroxetine or fluoxetine, and some dopamine antagonists. Or you always start with products like soy isoflavones or some soy products. Okay, that is a non-hormonal treatment of menopause. So that is about menopausal symptoms. That is with regard to hot flushes. But still, so far, even though we have talked about all these, we have not yet discussed the most important, most significant health problem of menopause, which is that the most important health problem in menopause is osteoporosis. How do you treat osteoporosis? Just write it down here. Osteoporosis in menopausal women. How do you diagnose osteoporosis? The diagnosis of osteoporosis is made by DEXA scan, by calculating the bone mineral density by a DEXA scan, dual X-ray absorptiometry scan, which is best measured at the, where do you measure DEXA scan? Best bone mineral density is best measured at the hip. All right. How do you treat osteoporosis? Before we start osteoporosis, like we start treating osteoporosis, like we always say, prevention is better than cure. You always tell menopausal women that they have to take calcium, vitamin D, and do regular exercise. But once you detect that the woman has got osteoporosis, she's menopausal, you have to start a treatment. The first line of treatment for osteoporosis in menopause is bisphosphonates. I'm pretty certain you've studied this in pharmacology, also in orthopedics. What are the bisphosphonates that you give in osteoporosis? Drugs like alendronate and bisandronate. Now, the second line drug, once you've given bisphosphonates, if you're going for a second line, the second line option would be a combined estrogen progesterone, tibolone, like we said, then selective estrogen regulators like estrogen receptor modulators like raloxifene. Okay, those are the second line drugs. But remember this, osteoporosis is the most important health problem in menopause. You measure the bone mineral density using the DEXA scan, best measured at the hip. Calcium, vitamin D, and exercise are what you advise first off. And the first line treatment is in the form of bisphosphonate, like alendronate and bisandronate. All right, that is with regard to osteoporosis. Now, I've got a question. Suppose this woman has come to you. She's having menopausal symptoms. Say she's got hot flushes. She says that she's post-hysterectomy. A woman who's 40 years old, say she has undergone hysterectomy. She's coming to you with menopausal symptoms. What do you give her? First of all, whenever a woman who has undergone hysterectomy comes to you, the first question you should ask should be, why was the hysterectomy done? What was the indication for the hysterectomy? If the indication for hysterectomy was endometriosis, then you should not give estrogen alone, even if she is a post-hysterectomy patient, because there will be uterine tissue in other parts of the abdomen, and she may develop endometrial hyperplasia there. In case of a woman who underwent hysterectomy for endometriosis, again, combined pills with estrogen and progesterone will be your best option. Now, there are certain conditions where menopausal HRT is contraindicated. We'll put it down as A, B, C, D. Menopausal HRT is contraindicated in these conditions. A, for acute liver disease, if the woman has got acute liver disease. B, she has bleeding PV, which is undiagnosed. You don't know what it is. C, if she has a carcinoma of the breast or the uterus. And if she's got a history of DVT. In these conditions, acute liver disease, undiagnosed bleeding PV, carcinoma of the breast or uterus, and a woman with a history of DVT, you will not be administering hormone therapy. Let's take up the next question. Which of the following conditions cause heterosexual precocious puberty in female? What is precocious puberty? Precocious puberty is puberty occurring before 8 years of age. It is most commonly idiopathic. It is of two types. It can be isosexual, it can be heterosexual. Isosexual means the puberty, she has developed puberty, the girl has got puberty, and the pubertal developments are in accordance with her own particular sex. That is just like a girl. This can be due to ovarian causes, like, you know that isosexual puberty means she should have increase of female hormones. This may be due to granulosa theca cell tumors that secrete estrogen. This may be due to some adrenal feminizing tumors, or maybe due to ectopic gonadotropin production, as in, say, dysgerminoma or choriocarcinoma or hepatoblastoma. She may have exogenous estrogen in the form of contraceptive pills or some corticosteroids. And then there is this condition called McCune-Albright syndrome, which is also for isosexual precocious puberty. But remember, whatever it is, if the question is what is the most common cause, it is always idiopathic. Now, here our question asks for heterosexual precocious puberty. What causes heterosexual precocious puberty? Heterosexual precocious puberty means she has got hormones of the high levels of hormones of the opposite sex. That is, in this case, in the male hormones. The common causes include CAH, adrenal hyperplasia, ovarian or adrenal testosterone secreting tumors, and exogenous androgens instead of estrogens. Okay, so the condition that can cause precocious puberty here is late onset congenital adrenal hyperplasia. Another thing with regard to adrenal hyperplasia is, adrenal hyperplasia is the most common cause of ambiguous genitalia in female. Most common cause of ambiguous genitalia. The enzyme that is most commonly responsible for adrenal hyperplasia is the 21-hydroxylase. This is the enzyme that is responsible. This is followed by 11-beta-hydroxylase. This is 1 and this is 2. Now, what are the tests? I will not go into the details. How do you screen for this? You see 17-hydroxyprogesterone. If 17-hydroxyprogesterone is low, that is, if it is less than 200, you can rule out CAH. If it is more than 800, you can confirm CAH. But if it is between 200 and 800, you'll need a diagnostic test. The screening, I'll just put it down here. The screening is by using 17-hydroxyprogesterone, while the diagnostic test is the ACTH stimulation test. Okay. So, and what is the treatment? The treatment is by mineralocorticoids, glucocorticoids, and if there is ambiguous genitalia, obviously you will need surgery for ambiguous genitalia. If the non-pregnant girl, up to a puberty, you'll be giving a short-acting corticosteroid like a hydrocortisone. Why? Because if it is a long-acting steroid, it will affect the epiphyseal closure. After epiphyseal closure, you can start her on dexamethasone or prednisolone. Now, a woman with CAH becomes UPT positive. What will you do? You should start her on dexamethasone because it can cross the placenta. Once you start her on dexamethasone, you go for a chorionic villus sampling at 10 weeks. At 10 weeks, you find that it is a male, or if it is a non-affected female, what will you do? Male or non-affected female means this person will not have CH, or their genitalia will not be affected, will not develop precocious puberty. If it is a male or a non-affected female, you will stop dexamethasone and the woman can continue with hydrocortisone. But if it is an affected female, it requires treatment in the womb itself. So you will continue with dexamethasone. I hope this is a little bit confusing. It is. When a woman becomes pregnant, you will start her on dexamethasone. You will do a CVS at 10 weeks. And depending on what the results of the CVS, you'll manage the rest of your treatment. Okay. The next question. A 15-year-old female presents with primary amenorrhea. Her breasts are Tanner 4, but she has no axillary or pubic hair. The most likely diagnosis is, again, this is a question that you must have come across so many times. Let's look at the choices. You got Turner syndrome. What happens in Turner syndrome? All the secondary sex characters are absent. Here, the woman, the girl has got well-developed breasts. Breasts are Tanner stage 4. Now, Mullerian agenesis. Mullerian agenesis means MRKH, Mayer-Rokitansky-Kuster-Hauser syndrome, where the Mullerian structures will be absent. Secondary sexual characters will have developed normally. So that is one. And secondary sexual characters develop normally means she will have axillary and pubic hair. What about testicular feminization syndrome? Testicular feminization syndrome is a 46XY male, where the hair development will not occur. We had discussed before that hair development occurs under the influence of testosterone. Testosterone is converted to estrogen, so breasts will develop, but hair development, which is dependent on testosterone, will not develop. Do you understand the difference between MRKH, Mullerian agenesis, and testicular feminization? In Mullerian agenesis, it is just the Mullerian structures, the uterus and the uterus cervix and parts of the vagina that are absent. But the rest of the sexual characters will develop normally. In testicular feminization, uterus, ovaries are not there. The woman is not, she's resistant to testosterone. This particular person is resistant to testosterone. This is 46XY. Resistant to testosterone, breasts develop, but the axillary and pubic hair, which are dependent on testosterone, will not develop. So in this case, the answer is testicular feminization syndrome. What is premature ovarian failure or premature menopause? Now it is called POI, premature ovarian insufficiency. That is woman undergoing menopause before 40 years of age. How do you test for it? She is amenorrheic. She usually comes with menopausal symptoms. When she comes, naturally you'll test her FSH. We have discussed FSH before. You find that FSH is more than 40. You repeat it. Again, you find that it is more than 40. You make a diagnosis of a premature ovarian failure and start menopausal hormone therapy. Question 15. A 23-year-old sexually active woman presents with lower abdominal pain and fever. On pelvic examination, cervical motion tenderness is noted. Which of the following is not part of the additional diagnostic criteria supporting the diagnosis of PID according to the CDC guidelines? Pelvic inflammatory disease comes with, there are two different guidelines, the diagnostic criteria. First of all, you have got the minimal criteria for diagnosis. The minimal criteria. After that, you will have the additional criteria. They have asked for the additional criteria. What are the minimal criteria? There are two minimal criteria. First one is pelvic pain, pelvic or lower abdominal pain, pelvic or lower abdominal. Note that this is a minimal criteria for diagnosing PID, pelvic or lower abdominal pain. Then you will have cervical motion tenderness or adnexal tenderness or uterine tenderness. These are the minimal criteria for diagnosis of PID. Now we come to the additional criteria. The additional criteria include, first of all, fever. Fever. Then you have abnormal cervical mucopurulent discharge. You have the mucopurulent discharge. Then on saline microscopy, you'll be able to see WBCs. The inflammatory markers are elevated. What are the inflammatory markers? ESR and CRP are found to be elevated. If you do a microbiological testing, you can do a microbiological testing. A microbiological testing will confirm the cervical infection with chlamydia or Neisseria gonorrhea. These are the additional diagnostic criteria. You have got the minimal criteria and you have got the additional diagnostic criteria. But these are not the specific criteria. The most specific criteria, which are actually not necessary for diagnosis, the most specific criteria is by the endometrial biopsy. Endometrial biopsy will show, with histological evidence, will show endometritis. Or there are pelvic imaging, which will show thickened fluid-filled tubes or free fluid in the pelvis or a tubo-ovarian abscess. Or you can do a laparoscopy, which will show abnormalities like dilated hyperemic tubes or pyosalpinx or tubo-ovarian mass. Anyway, these two are the ones that you really need to know. What are the minimal criteria? What are the additional criteria? Pelvic lower abdominal pain, cervical motion tenderness, adnexal tenderness, uterine tenderness are the minimal criteria, while the other 5, fever, discharge, WBCs, microscopy, and inflammatory markers are the additional criteria. Let us just look at the choices once more. Which of the following is not part of the additional criteria is the question. Presence of WBCs, yes. Microbiological testing, yes. Pelvic pain or lower abdominal pain, is it part of the additional criteria? No. Pelvic or lower abdominal pain is part of the minimum criteria that are needed to diagnose PID. How do you manage PID? Management of PID is either on OP basis or on IP basis. If it is on OP basis, a management on OP basis, you have to know the management also. Management, you give ceftriaxone. Ceftriaxone, 1 gram, single dose, intramuscularly, single dose, plus doxycycline, 100 milligram, BD orally, plus metronidazole, 500 milligram, BD orally, these two for 14 days. That is the OP management. Or instead of ceftriaxone, you can also give cefoxitin. But this is the one that you have to remember, ceftriaxone and followed by. Now, what about IP management? When do you give IP management? IP management is given when there are severe symptoms. There is a suspected tubo-ovarian abscess, or the OP management has failed, or there is an inability to doxycycline and all difficult drugs to take. There is an inability to tolerate the OP management. The woman is pregnant, or a surgical emergency cannot be ruled out, or like say appendicitis. She's severely immunocompromised. In that case, you go for an IP management, which also is started with ceftriaxone, 1 gram, IV OD with doxycycline is also given, preferably IV, or if the woman cannot take it, you can give orally also. But the drug is ceftriaxone, which is given IV. That is the IP management. Okay, the drugs are the same. It is just that ceftriaxone is given for a longer period of time as intravenous dose in IP management, right? A 29-year-old nulliparous woman complains of severe menorrhagia and lower abdominal pain since 3 months. On examination, there was a 14-week size uterus with a fundal fibroid. What is the treatment of choice? Fibroid they've already given. How do you manage fibroid? Fibroid is managed based on the symptoms. If she is asymptomatic, previously I had already said that if the fibroid size is more than 12-week size, you should always go for a surgery. Here it is a 14-week size uterus. But now that is no longer there, you treat the patient based on the symptoms. If the woman is asymptomatic, you can wait and watch, or you can go for offer her a surgery. If symptomatic, then you'll have to treat it, whether medically or surgically. Here, she is symptomatic. She's got severe menorrhagia. She also has lower abdominal pain. So this has to be treated. What are the medical management? Let us just go for the medical management quickly. The main medical managements include ulipristal. You're familiar with these drugs. Letrozole, NRH agonist, antagonist, mifepristone, danazole. These are all the main medical management. As far as surgical management is concerned, there are 3 different kinds. First one is myomectomy. Then you've got embolotherapies, and then like uterine artery embolization, and then you've got hysterectomy. Let us look at that question. Here she is a nulliparous girl. She's only 29 years old and she's nulliparous. She's symptomatic, so she requires surgery, but she's nulliparous. You cannot take out her uterus. You cannot offer her embolotherapy. So in this particular case, the best treatment for the girl is myomectomy. Okay. That is where you've chosen. I hope that you're familiar with the FIGO classification of fibroids. Please go through that, or if you've got a picture, just go through the picture with regards to the FIGO classification of fibroids also. Now, next question. We have a 28-year-old female presents with chronic pelvic pain and dyspareunia. She has a history of dysmenorrhea and infertility. A pelvic ultrasound suggests endometriosis. A laparoscopy is performed, revealing multiple powder burn lesions on the pelvic peritoneum and ovaries. What is the most appropriate next step? Management. They've already given your diagnosis. The diagnosis is endometriosis, which is by definition the presence of endometrial glands outside the uterine cavity. You know that there are a lot of theories for endometriosis, of which the implantation theory or the theory of retrograde menstruation is the one that is most commonly accepted. So what do we understand? Endometriosis is an estrogen-dependent condition. The risk factors include family history, like estrogen, prolonged exposure to estrogen as an early menarche, late menopause, nulliparous woman, high socioeconomic status, mullerinegenesis. But here, what we need to know with regard to endometriosis, couple of things. First is the most common site. This one you know, which is the most common site of endometriosis? It is the ovary. The most common extrapelvic site. The most common extrapelvic site is the sigmoid colon. The rarest site of endometriosis is the CNS, while it is not seen where? Not seen in the spleen. Okay. Now here in this question, let us just, what were the clinical features that she talked about? Severe pain, chronic pelvic pain, dyspareunia, dysmenorrhea, infertility. And they've already said that it is endometriosis. How do you diagnose endometriosis? What are the methods to diagnose endometriosis? The investigation of choice for endometriosis is a transvaginal ultrasound. I'm sorry, this is the first investigation for endometriosis. The first investigation for endometriosis is a transvaginal ultrasound, where you'll be able to make out a ground glass appearances with the ground glass appearance, that's the endometrioma. That is the first investigation. But the investigation of choice is a laparoscopy, which they have done here. They're with direct visualization of the lesions. How will the lesions appear? There'll be powder burn or endometriomas, or you'll be able to see adhesions. But still, this is not the gold standard. The gold standard for the diagnosis of endometriosis is by histopathologic examination. Okay, that is with regard to the diagnosis. How do you manage it? The main management goal solution will be very symptomatic. So it will be to alleviate the symptoms, to decrease the pain, to improve the fertility outcomes, or to prevent the progression of the disease. So there are multiple treatment options. As always, we'll start with medicines, which include contraceptive pills or progesterones or GnRH agonists, or you can opt for surgery, where these lesions can be excised or ablated, especially in cases with severe symptoms like severe pain that is unresponsive to medicine. She's got infertility issues or large endometriomas. See, look how it is, the powder burn appearance of endometriosis. So all these lesions have to be excised. Right, next question. A 15-year-old girl comes to the OPD with complaints of heavy menstrual bleeding since 2 months. A 15-year-old girl, heavy menstrual bleeding means this is puberty menorrhagia. On examination, her weight is 40 kilograms, BP is 120/80. All of the following investigations are indicated except. Okay, so this girl, she is having puberty menorrhagia. What are the causes for puberty menorrhagia? The most common cause is anovulation, which is due to the immaturity of the HPO axis. Then we have also got blood disorders like some kind of dyscrasias or coagulation disorders, which is the second cause. Then we have got the endocrine causes. Okay, so you'll have to go through what, since we already discussed that she has got, she may have some bleeding disorders. It is important that you check her bleeding time and clotting time and her platelet count, and also to rule out endometrial causes, the TSH. But estradiol levels are not indicated in a woman, in a girl coming with puberty menorrhagia. How do you treat puberty menorrhagia? Basically, the most common cause is due to anovulation. So anovulation means there will be continuous action of estrogen. Progesterone will be low in anovulatory cycles. So what we do is we'll give progesterone for the second half of the cycle. That is the treatment. The treatment of puberty menorrhagia is progesterone, which is given in the second half of the cycle to prevent the unopposed action of the estrogen. Okay. The most common histological finding of endometrium in DUB is, without much ado, we'll go for the answer. The most common finding is hyperplastic. If you had a choice of a normal secretory endometrium, that would have been your most common finding. A normal secretory endometrium is the most common finding in DUB, which is around 60%, which is followed by the hyperplastic endometrium. Then you've got irregular shedding, irregular ripening, or atrophic endometrium. I believe you have already heard of, or you must have read upon Halban's disease. So that is with regard to DUB. Most common is normal secretory. Since that is not there in the choice, we'll go with hyperplastic. How do you treat? Again, like we said in the case of puberty menorrhagia, treatment is by progesterone. Question 20. A 35-year-old woman with children aged 5 and 6 years has a history of amenorrhea and galactorrhea. Blood examination reveals increased CT head is likely to reveal. You have got the choices. CT head is in all likelihood likely to reveal a pituitary adenoma or a prolactinoma. That is why there is increased prolactin. When you look at the choices, the other choice that is likely to present this way with amenorrhea alone is Sheehan syndrome. Sheehan syndrome or empty sella syndrome. Why is it caused? It is caused usually due to pituitary necrosis as a result of probably postpartum hemorrhage. But the symptoms include not galactorrhea, failure of lactation. There will be secondary amenorrhea. There will be loss of libido, and because there has been a pituitary necrosis, there will be hypothyroidism or increased sensitivity to cold. Anyway, in this case, it is more likely to be a prolactinoma or a pituitary adenoma. Now you come to the postmenopausal women. A 52-year-old menopausal female presents with a single episode of postmenopausal bleeding. TVS shows endometrium with uniform thickness of 3 millimeters. What is the most appropriate step in management? How do you manage postmenopausal bleeding? For that, first of all, we have to discuss causes of postmenopausal bleeding. The most common cause of postmenopausal bleeding is endometrial atrophy. Like in this case, the endometrial thickness is only 3 millimeters. This is followed by a hormone replacement therapy. There can be an endometrial polyp or a carcinoma of the endometrium. Whenever a woman comes with postmenopausal bleeding, even if it is her first episode, you'll have to investigate her. The first investigation is transvaginal ultrasound for endometrial thickness. Now you find that the rest of the management and the investigations will all depend on the endometrial thickness. you find that the endometrial thickness is less than 4 millimeters. Very sorry, in between. We'll come back to the question. Can you hear me? Can somebody please replay? Can you hear me?
Yes.
Yes, ma'am.
Okay, we'll take up question 21. So we were talking about postmenopausal bleeding. Now we have done an ultrasound. We find that the endometrial thickness is less than 4 millimeters. What do you do? In such a case, if the endometrial thickness is less than 4 millimeters, endometrial thickness less than 4 millimeters, you ask the woman to review after 3 months or earlier in case bleeding occurs. Now you find the endometrial thickness is more than 5 millimeters or more. Here we have
Madam is facing some network problem. അവിടെ ഹെവി റെയിൻ ആയിട്ടേ കോട്ടയത്ത് ഹെവി റെയിൻ ആണ്, നെറ്റ്വർക്ക് ബ്രേക്ക് ചെയ്തുകൊണ്ടിരിക്കുകയാണ്. അതുകൊണ്ട് മാഡം പറഞ്ഞു നാളെ 8-ന് ബാക്കി കണ്ടിന്യൂ ചെയ്യാം. So we'll wind up today's class now. So we'll try to have the remaining 1 hour session tomorrow at 8 o'clock. Okay. Thank you. So we'll wind up today.
Okay, sir. Thank you.